Thank you for choosing Axxess On Demand. We're the fastest growing home health technology company, helping improve care for more than 1.5 million patients and trusted by more than 7,000 healthcare organizations to grow their business. Axxess is a firm believer in continuing training, and we create content so you can learn and grow anywhere, anytime. Let's get started.
Hello, this is Jennifer Gibson with Axxess, and welcome to our continuing series on the updated home health conditions of participation. Today we're covering part 6 of our series, which entails the infection prevention and control measures that will be implemented with the updated home health COPs. Our objectives today are to learn who is responsible for the agency's infection prevention and control program, to become knowledgeable in new requirements for infection prevention and control, to identify what the agency should be monitoring, and to understand what the agency should be educating patients and staff about in regard to infection control. As a matter of reference, let's look at our current conditions of participation for home health and see what we are responsible for now. Currently, there is no requirement for agency-wide infection prevention and control programs, but we do have to comply with accepted professional standards, which do include infection prevention and control measures. So currently, we don't have a lot of regulation, at least not on the federal level. You certainly may have certain regulations depending on your accrediting body, such as Joint Commission or CHAP or ACHC. But as far as the federal level, we don't have a specific requirement. So there will be some big changes when the updated home health conditions of participation come into play. You'll find the infection prevention and control regulation under Subpart B of 484, and the actual location is 484.70, and you see this is now part of the patient care section of our home health regulations for conditions of participation. At the preamble at 484.70, we are told that the agency must maintain and document an infection control program which has as its goal the prevention and control of infections and communicable diseases. Then we start to see our standard. The agency must follow accepted standards of practice, including the use of standard precautions to prevent the transmission of infections and communicable diseases. So we have several things to factor in here. So again, there are 3 parts to this particular infection prevention and control program. When we talk about the prevention, we have the accepted standards of practice, including the use of standard precautions to prevent the transmission of infections and communicable diseases. Now remember, your standard precautions include hand hygiene, personal protective equipment guided by risk assessment and exposure to body substances and fluids or contaminated surfaces before any healthcare activity, and then things such as respiratory hygiene and cough etiquette. Now, your World Health Organization has real good information on standard precautions in healthcare. When you're getting ready to write your policies and procedures or review and update those, you'll have a really good source there as far as which different types of personal protective equipment you need to use for what kinds of processes and procedures. You'll be able to find that easily as well. At 484.70, we see the standard gets into the control. So we just talked about the prevention of infections. Now we're going to talk about control. And in order to control infections, the home health agency has to maintain a coordinated agency-wide program for the surveillance, identification, prevention, control, and investigation of infectious and communicable diseases. That's an integral part of the home health agency's QAPI program. Now, as we said earlier, quite often agencies will have an added layer of regulation due to their accrediting body, such as Joint Commission or CHAP or ACHC regulation, that's more stringent oftentimes than the federal regulation under which we currently practice with the COPs as they are now. And for that reason, you may already have some programs that require you to do surveillance, identification, prevention, control, and investigation of the infectious and communicable diseases that might be apparent in your agency. However, they're not always integrated into your QAPI program. I know for Joint Commission they usually are, but not necessarily the others so much. I'm sure they do have some aspects, but we're going to see that become more stringent under the conditions of participation, because in order for you to participate in Medicare money, you must now, under the new conditions of participation when they come into effect, have all of these different pieces under control and part of your QAPI program. So the agency will now have all of these different pieces that are not only being monitored and maintained and followed up, but now we have to have that person who is doing the infection surveillance and making comments to follow up and so on. Not only are they reporting to the DON or the QAPI committee, but now it actually has to be part of that QAPI program on an ongoing basis. So let's talk for a little bit. What I want you to think about as we go forward is some of the questions that you see on the screen here. For example, who must participate in the infection prevention and control program? How are your contracted and part-time clinicians involved? What are your agency's policies regarding infection risk assessment and infection surveillance? Who's the designated infection control specialist in your agency, and has that person been properly trained? So does the person who actually looks at and reviews those infection control reports, has that person been trained formally on infection prevention and control? What training do you give your employees regarding infection prevention and control? Are staff members proficient in identifying and preventing infections? What kind of personal protective equipment is available to your employees? Do you offer employee and or patient vaccinations? Do you require TB screening upon hire and then periodically thereafter? And then who investigates the infection reports in your agencies? Those are the kinds of things that you need to be thinking about as you look at the regulation going forward, okay? At 48470B, the standard again is still control. We are told that our new infection prevention control program must include a method for identifying infectious and communicable disease problems and a plan for the appropriate actions that are expected to result in improvement and disease prevention. So you think about, for example, do you have risk assessments done for which kinds of patients you might be doing? Have you trained your clinicians on how to use that personal protective equipment? One example that comes to mind in that case has to do with the particulate respirator for TB patients who have tuberculosis. Those are special masks, of course, that have to be ordered. When you think about, how often do you get those patients? Most of us do not get an active TB patient very often at all. And if you're going to take that patient, certainly you have to be well prepared and have the particulate mask respirators in-house, and that they're specially fitted for your clinicians, and that they know how to do the special fit test and have been trained on how to don and doff that particulate respirator mask, for example. You can't just put on a regular little mask and go. So those are some things that you're going to have to be thinking about when you think about your infection prevention and control programs. And then the method for identifying infectious and communicable disease problems. Do your clinical staff know all of the different symptoms of infections and different communicable disease problems? Are they aware? Do they do thorough assessments enough to pick up on those different symptoms early and even prevent them, hopefully, before they even occur? And then once they pick up on those symptoms, what actions are expected? Do they call the office? Do they call the doctor? What do they do immediately? You should have some plans in place as well. At 484.70, we see the standard C, which is Infection Prevention and Control Education. And in the new conditions of participation for home health, we are shown that the agency must provide infection control education to the staff, the patients, and caregivers. So we have to now be teaching all of these different persons about infection control, prevention, and control, right? So that's going to entail many different things, including hand hygiene, cough hygiene, the use of personal protective equipment, when and what types to use, and so on, not only to our staff, and by staff we mean not just those that are full-time, but full-time, part-time, contracted staff, volunteers, and so on, and then also the patients and the patients' caregivers. And caregivers, we mean not just legal caregivers, but also that patient-chosen representative as well. So again, the standard here at 484.70C talks about education. We're talking about teaching and education for the patient, the caregivers, and the employees, including contracted or part-time employees as well. That's funny, when thinking about the infection prevention and control programs and home care in general. I've started my home health career in November of 1993, and certainly when you think about home care and how it has evolved, if you've been in home care more than just a few years, you certainly see that home health and home care has broadened in the type and scope of patients that we take care of in the past decade. Patients are receiving more and more invasive procedures at home than they did in the past. We do a lot of home infusion therapy, tracheostomy care, ventilator care, PEG tubes, catheters, dialysis, and we do more and more invasive procedures at home because of all of these different evolving technologies. We also have LVAD therapy, the ventricular assistance devices, cardiac drugs that are IV 24 hours a day. I mean, there's just so much going on in home care that we didn't do years and years ago. All of those different procedures certainly increase the patient's risk of developing an infection. So that's why we really have to think about how we're going to prevent infections as well as control those that the patient has when we admit them to home care or readmit them or resume them even from a hospital stay. We also know that home health nurses and other staff members provide skilled care to post-operative patients, postpartum mothers and newborns, acute medical conditions like newly diagnosed diabetes and recent strokes, wound care patients, patients who have a lot of different comorbid conditions, and again, all of these different things cause that patient to be at higher risk for developing an infection. So we have to really hone in on our skills, our assessment skills, and our training to make sure that our patients and caregivers also understand what to look for and how to prevent infections. According to an April 2001 CDC article, and I know that's kind of an old article, but there's really not a lot available that pertains to home health. But this particular article said infection control and healthcare epidemiology have not kept up with the needs of the home care providers and their patients. And so this is now addressed in the updated home health COPs, wherein we're trying to keep up with making sure that the patient's infection control needs are met, right? There's a link on the screen to actually view that article if you should want to for any reason. When you think about the advancement of all the different things that we do in home health, the procedures, the processes, the acuity of the patients that we now have at home, we see that the infection control in home health relies on clinical signs and symptoms, tests such as urine dipstick, and then a team approach or team effort, whereas infection control methods in acute settings are impractical for home health, like laboratory tests and cultures. We get orders for those, but not as quickly and routinely as do our cohorts in different settings. We also see that in acute care settings, there's normally a designated infection control nurse or other person who reviews medical records and assesses patients for infection. And that's kind of impractical in home health because of the logistics of the patients that we see. One person is usually not in charge of overseeing infection for everyone. The visiting clinicians and the case managers end up being separate little teams that then report back to the office through infection control reports, and those infection control reports may be seen by one person or a group of clinical managers in the office, but you don't have just one designated person. Usually, it's the clinical field staff that fills the infection assessments and control and education. However, we do see some changes in technology that have allowed for more options for home health infection control measures. We now have the ability to order, especially in large metroplex cities, at least, mobile x-rays and mobile labs. And of course, we can get orders to do labs as well and have those sent off for analysis. So we're seeing some adaptation for home health setting, but still it's not as easy as it might be in other settings that are brick and mortar, let's say. According to this report that I read, home health patients may have less acuity, which means less intensity or degree of care than the acute care setting. And what they mean by that is certainly the person who is able to come home and receive intermittent or part-time skilled care are not as acute as a person who might be in the hospital for days on end or even in ICU or post-op care. So there's a little bit less degree of care than in an acute setting, but they still have more substantial risk factors like the advanced age, the chronic illnesses, immunosuppression, and then we run into quite often less structure and control of the environment and the care setting. We run into issues with plumbing and sanitation and ventilation and pets, and certainly if you've ever tried to put in a Foley catheter and had a cat or a dog jump into your sterile field and you have to scratch that and, take everything apart and put the dog away or make sure it's corralled up and then go get another cath kit out of the car or at the office and go and try again, you certainly know what we're talking about here. And that's a very common thing that our brick and mortar cohorts do not have to deal with. They usually have an extra person available to hold legs and abdominal folds and such out of the way. But we don't always have that in home health care, do we? So we do have a lot more challenges in many cases in the infection prevention and control genre that we have to think about. Now, there is no one single correct method for infection prevention and control. So CMS did not write specific guidelines. They gave us at the agency level the leeway to develop our own infection control programs. And we need to do that based on the population that we serve, the services that we provide, and those regulatory standards for our agencies, depending on if we're Joint Commission, ACHC, CHAP accredited. Then we have to look into our state regulations, our professional practice acts, and so on, and then the population that we serve. If we're doing kids and pediatrics, their infection control may be completely different than the adult. We may have to start thinking about, for pediatric patients, teaching the parents on how to disinfect toys and games and equipment that we may not think about with adults, right? And even with the adults that we serve, we may get into thinking about the devices that they use. This is kind of gross, but when you think about the number of adults who take their smartphones to the toilet with them and use the smartphone while they're in the bathroom, we need to think about that and telling them to disinfect those phones, right? Or maybe not take them in there to start with, even better. Or I guess the best case would be to do both. Don't take it in there and make sure you clean that mobile device as well. As we become more and more dependent on smart devices and technology and remote controls and things like that, we need to be really smart about teaching patients how to take care of infection control prevention in that way as well. I know certainly with me, I had a roommate at one point who had a small child, and we had the flu in the household, and so we got really smart about making sure that doorknobs and refrigerator handles and remote controls were sprayed with Lysol and or put inside a Ziploc baggie to keep the remote control from being contaminated and such as that. So there's lots of different things that you can implement as far as teaching and education that you might not necessarily want to write in a specific policy, but as part of your education, you can help with infection prevention and control based on the population that you serve. Your infection prevention in the home should focus on things such as home infusion therapy, implanted devices, urinary tract care, respiratory care, wound care, enteral therapy, C. diff, pneumonia, bloodstream infections, skin and soft tissue infections, flu vaccination rates, pneumonia vaccination rates, shingles vaccination rates, sharp injuries, and so on. Now, that's not an all-inclusive list. That's just a list of some of the things that we're going to focus on depending on the population that you serve. And especially the flu vaccines in value-based purchasing states, those particular agencies that participate in VBP states have to already keep up with the number of employees who receive the flu vaccine during flu season, and those who do not, they have to document why they didn't receive the flu vaccine. They declined it, or did they have an allergy to eggs, so on and so forth. And when you think about infection control and the flu, for example, we know that for our employees, that's a really good idea to go ahead and vaccinate or try to our employees as well, because with the flu, you can actually have the flu a full 24 hours before you're symptomatic and be giving that to patients, right? And so we don't want our patients to become ill, especially with all their comorbid conditions. So it makes sense that in order to keep them from having all the different complications and all the money related to caring for those complications, it makes sense to go ahead and vaccinate ahead of time. So that might be something that we look at as well. Your home health infection prevention should be a two-tiered program where home care clinicians identify and report clinical findings, and then you have an infection control nurse who reviews evidence and ascribes a definition. And what do I mean by definitions? You have common home care acquired infections. And so your infection control nurse needs to know the difference between a home care acquired infection versus community acquired or hospital acquired and so on. Those are some terminologies that are thrown around in infection control practice. And certainly if the person keeping up with your infection control surveillance records doesn't understand infection control, that might not be the best for your agency's outcomes. But the kinds of common home care acquired infections are things like urinary tract infections or central line infections or device-related urinary infections or bloodstream infections. Those are things that we commonly see in home health. I suggest that you have some tools available in your infection prevention and control program, maybe a screening tool that's done at admission or readmission or post-hospital especially, and that screening tool would assess for things such as fever or new antibiotic orders or purulent drainage from the wound, changes in the color or odor of urine, painful urination, respiratory rouse and rhonchi, increased sputum leukocytes, and so on. That screening tool should also bring the attention to inflamed skin that's red or hot or swollen or has a rash, or fever or chills, which is temperature over 102 degrees Fahrenheit, nausea, vomiting, and diarrhea that's unexplained by a change in diet or new medications. And often that's one that's overlooked unless it's just really bad. But if you've got a patient who's having nausea, vomiting, or diarrhea, and they haven't had a recent change in diet or medications, that's an infection symptom right there that we need to get on top of. Pain, like a sore throat, or pain that's disproportionate to an injury, can also be a sign of infection. A productive, persistent, or new cough, or a change in consistency or color of sputum. Those are some things that you can put on a screening tool for your clinicians to fill out and turn in. And the reason that's so important, especially on admission or readmission or post-hospital assessment, is that symptoms, if they show up within a certain period of time, those are attributed to the hospital stay or the acute care setting, and not to the home health agency. Whereas if you don't document those symptoms or assess for those specifically during those time periods, those can then be assessed to your agency as causing the infection. The infection screening tool minimally should be done on the initial assessment. I would also ask if the patient has a history of tuberculosis or tuberculosis exposure, and many of our accrediting bodies already have us do that. Do they have a history of antibiotic-resistant organisms? Many times, unless they have a VRE or MRSA condition or exposure documented, we don't always think to ask those questions. And patients certainly could have had problems with staph infections years ago that they don't think to mention, or it's not documented now. So we should assess for that. Also, have they had any chronic infections? Do they have chronic bronchitis, or do they have chronic UTIs? Do they have a skin or soft tissue issue like boils or cellulitis? Are there infestations like scabies or lice? GI illnesses? Do they have an acute respiratory illness or continence issues? Certainly, we know if a patient's incontinent, that increases their risk for skin breakdown, but it also increases their risk of urinary tract infections. And then we need to also assess if that patient is able to comply and cooperate with hand hygiene. We can educate the patient and the caregiver all the time in the world about infection control, but if they are not able to reach a washcloth or hand sanitizing gel, or if they have mental issues, dementia or psychiatric issues, for example, that prevent you from safely keeping alcohol gel or hand hygiene items close to the patient, or they don't remember to use it, certainly that's not going to help either. So we have to make sure that we think about not only the teaching of the patient, but assessing their ability to comply and cooperate with hand hygiene and other infection control measures. And then again, as we talked about, it's a good idea to do that after hospitalization, because during a certain period of time, those infections are attributed to the home health agency and not the hospital, depending on what you find and what timeline you're looking at. And then your assessment should be ongoing with all patient interactions to make sure that we're assessing for infections. Head-to-toe assessment on every visit's imperative for what we do, and thinking about any kind of infection symptoms and reporting those early can be make or break for the patient and, of course, our agencies as well. Your infection prevention and control program should make sure that you have a designated nurse who reviews evidence such as clinical signs and symptoms, laboratory data, clinical notes, and progress notes. And then that designated nurse would apply the clinical definition of home care acquired infections versus hospital acquired infections and so on. Some terms to know in your infection prevention and control program. CLABSI is a central line associated bloodstream infection. CAUTI is a catheter associated UTI. And HAI is healthcare associated infections. Whereas non-HAI, of course, makes sense. That's something that the patient acquires without the healthcare person having any bearing on that infection at all. And then a nosocomial infection originates or takes place in a hospital, or it was an acquired in the hospital infection. So you'll see that quite often when you're researching infection control programs or infection control in general. Those are some terms you'll need to know about. In some of the online research that I was reading, reports and such, it was stated that surgical site infections should be rare in home care settings if the wound is primarily closed and there are no drains left in place, which really makes sense. A lot of times in home care, we get infections in surgical sites that were already present on admission. That usually takes the place of a dehiscence or a wound infection and that kind of thing. We may see sutures in place that have open places between sutures and it's draining and so on. Whereas if that wound is already closed by primary intention and there's no drain in place, it really is a bad thing if you end up with a surgical site infection after the patient comes home from the hospital. So again, that just reinforces the fact that we have to be really particular about assessing patients who are admitted to home health with surgical sites. We need to make sure that we document any redness, any symptoms of infection immediately, and contact the surgeons and the physicians who referred the patient to home health. So certainly if the patient comes home with a surgical incision and a week later they end up with an infection and we haven't documented any symptoms until that week later, then that's going to show very poorly upon our agency and our staff. And if you have those kinds of situations, I would even go a step further and say, as a DON or an administrator, I would want to be going out and assessing the clinicians involved in that patient's care and see how they're doing with hand hygiene and personal protective equipment use and being aware of their surroundings, and even bag technique, which I know is kind of out of vogue right now, but it certainly makes sense, of course, to be aware of clean and dirty sides of your bag and not re-entering or touching the bag after you've been in the patient's home, and hand washing and that kind of thing. So I would want to assess the skill level of my clinicians if I'm having certain infections going on in the home. We also see that the use of barrier precautions are different in the home. Gowns, masks, and gloves are really more to protect the employee and prevent patient-to-patient spread of infections than they are to protect a patient from the employee's symptoms. We also know, of course, about standard precautions. We have specially fit masks for patients with active TB infection that we talked about. And then again, with colonization and MRSA patients, we have to be particular about things like leaving the stethoscope and blood pressure cuff in the home, or maybe seeing that patient as the last appointment of the day, or see them after all of our high risk of transmission to other patients like wound care and IV patients. And that's just some things to think about to prevent spread of infection again. And we don't always think about that, and or we may not think to train our clinicians about those different types of things on an ongoing basis. Or maybe the clinicians have been trained, but our scheduler doesn't really think about scheduling those patients appropriately and keeping the MRSA patient at the end of the day and making sure that the clinician is aware. So those are some things to think about as well. In addition to the points and references that we've made so far, I wanted to give you some information and resources that are free to you to help you as you're implementing your infection prevention and control program and writing your new policies and procedures. One of the most wonderful resources that I know of come from the Home Health Quality Improvement organization, and you'll notice that there are many best practices or BPIPs on their website. And I've given you the link here on the page that you see. You'll notice, for example, they have an infection prevention test, and it has answer keys and references as well. But this is really a good test that you can give either before and after staff education. So when you bring your clinicians in and you're training them on infection prevention and control, you can do a pre-test and see how much they know baseline, do your teaching, and then give this test afterwards to show whether or not they learned anything. And that's really good to do to show competency. But I wouldn't just give the test with no education. And so I've copied on your slide here a couple of the sample questions from the Home Health Quality Improvement website that you see here. And there are many, many different BPIPs and different little tests that you can use. And those are free resources from HHQI for you to download. Another thing that they have for you in their BPIPs or best practices are little tools that you'll see, such as in this particular case, we have a urinary catheter management zone. It's kind of like we call them the red light or drill down. You have a green zone, a yellow zone, and a red zone. The green zone tells you this is what kind of symptoms you'll have if everything's okay. And then the yellow zone is kind of a warning symptom. You know when to call someone. You go ahead and call them today if you see this kind of problem. And then the red zone would be more like call immediately. Don't wait until sometime today. Call immediately. Call the home health nurse. Do what you need to do. And you notice that they've even been kind enough at HHQI to let you put your agency's logo in the upper right-hand corner and use these as patient teaching guides. And since patient education is part of the regulation that we see under the updated home health COPs, these tools can be very, very good for you. Other complementary HHQI tools and training topics include things such as vaccinations, your catheter management, the green, yellow, red, like I just showed you, your catheter UTI rate reduction, surgical site infections, MRSA, even bulletin board tools that you can put up in the office, which help keep this front of mind as you're trying to teach your staff. These bulletin board tools can come in very handy, and also hand hygiene tools and training topics. Some of the information in that CDC report in 2001 talked about some unnecessary practices in home health. And again, we go back and forth as to what is in vogue and not in vogue for home health anymore. And you'll need to make sure you refer to your accrediting body regulation. But some of the things the CDC said were unnecessary practices in home health included things such as nursing bag technique, or routine disinfection of non-critical devices like stethoscopes and blood pressure cuffs, or discarding irrigation fluids at set intervals like every 24 to 48 hours. And they said that these particular practices are unnecessary and costly. And I can remember in the early mid-90s when literally we used to carry around in home health agencies bottles of aerosol cans, of staffine that we were told to spray our blood pressure cuff and our stethoscope and our nursing bag and the scales and everything with that before and after each patient interaction. And then I've even had agencies that had us put like a paper towel barrier on the person's arm before we put a blood pressure cuff on. So when you think about all those different resources and supplies and how unnecessary that really was, because we're trying to protect ourselves from the patient and not vice versa. You see just how silly that seems. And the CDC report showed that, yeah, we're right. That is kind of unnecessary. A funny thing to note for those of you that are here in Texas or Arizona or other really hot summertime places, maybe even like Mississippi in the Deep South, you can probably relate to this. The agency that I worked for that had the staffine aerosol cans, we actually had a healthcare worker that left that in the back of the car, back seat, and that's where they kept their nursing bag between visits, and they would spray it down and then set it in the car, of course. That staffine, it got so hot in the summer that can exploded and hit the windshield and busted the windshield out. And I think that's when they really, in that particular agency, that's when they thought about maybe that's not such a great idea. Maybe we'll get away from that. I don't know how long it would have taken had we not had an incident. But anyway, I digress, but that's a little funny that some of you might be able to relate to. The CDC report also said instead of doing those things that are unnecessary, do these things instead. Use containers of fluids that will be used up in 2 to 3 visits. Avoid contaminating fluids by proper handling of the fluid cap and storing items away from children and pets. And if you're going to use a small bottle of normal saline, of course, and you're going to use it for 2 or 3 visits, you're going to make sure that that cap is turned which way? Opening side up. You don't ever take the cap off and put it opening side down on a table. Those are things that we're talking about here. We need to make sure we have the caregivers making sure we refrigerate enteral feedings or TPN and so on. We need to make sure there's meticulous care of kitchen appliances and tools such as blenders that are used in enteral feeding prep. You know, those enteral feedings can be really thick and clingy. So, you don't want them just to rinse those out. We want to really clean those blender parts, the measuring cups and spoons, and keep them in the dishwasher and let that steam help keep those clean. Now, sterilizing is probably not necessary according to the CDC report, but certainly keeping them cleaned with hot water and soap and that kind of thing is a good idea. And I don't know about you guys, but I don't know that we always do that. We don't always assess what they're using when they're giving pureed foods and so on. And I've had certainly a lot of enteral feeders or people who have to have soft or thickened fluids and that kind of thing because of swallowing difficulties who end up with GI problems. And so it makes you wonder if you went back and looked at all the different tools and appliances, could we maybe find a reason for that looking back? But again, those are things just to think about as you create your teaching and your prevention programs in your agency. So what should you do now to get ready for the COPs that are coming? Number 1, you want to identify an infection prevention and control nurse. You want to define all your infection control procedures. Look at your processes and procedures you have now and look at updating those or what you might need to add. You're going to want to devise a reporting mechanism for exposures and expected infections, identify the source and the extent of exposures and infections, monitor infections in patients and employees. If you have an employee who calls out sick because they have diarrhea or they have the flu or they have whatever, you want to document that as well as the patient. You know, monitor that as well as the patients, because that employee could be spreading infection inside the office, right? That's why quite often we tell nurses and other clinicians, if you're sick and you're running a fever, stay home. Don't bring that to the office and don't take that out to the patients. You'll want to create vaccination and TB test guidelines. You're going to want to implement respiratory protection plans and then track and report all your infections and make sure that's reported to whom? To your QAPI program and your board of directors and the governing body, I think is what they're called now, in the new COPs. You'll need to research and evaluate your agency's policies, pay attention and include federal, state, and accrediting body standards, and remember, when the surveyor comes in, they're going to grade you according to the most stringent regulation of the three, okay? Make sure you identify your intent and know how to demonstrate compliance with your infection control and prevention program. Update your policies as needed, and then educate all your staff on infection and prevention policies and procedures. Make sure the staff is demonstrating compliance. And as we said before, do that especially if you have some kind of home health or hospice acquired infection. You have a patient who has been on services for a week or two and they end up with central line infection or a PICC line infection or whatever. You're going to want to go out and assess whether or not that clinician is complying with infection prevention and control policies and their ability to show compliance with and understand those. Your staff should know how often to report infections and when, how to document on infection risk tools, infection reporting tools, incident reports, and then in the patient's chart or encounter note. You'll need to know what charts are to be reviewed related to infection prevention and control, how often the chart review will take place. Make sure that staff knows how to properly perform hand hygiene and how to educate the patient or caregiver on hand hygiene as well. And remember, when we're talking about educating patients and caregivers, keep that on a very simple, easy to understand level. Make those teaching handouts good for people who are not English proficient, perhaps. I usually keep those on like a 6th to 8th grade level at the most. I have for you some other resources as well. Again, your home health infection control BPIPs from homehealthquality.org. Your hand washing handouts. There's a really good one here from the APIC organization. You see the CDC report on home health infection control that I referenced a few times during my presentation today. It's a good article to read if you'd like. It's not real long either. You'll also want to make sure that you look at the CDC's notifiable disease list, which is frequently updated. Your policy will need to address how often you look at that CDC site, and will need to reference that that's where you get your list of notifiable diseases and immunization guidelines, and those change at least yearly, by the way. So make sure you have the CDC's website. Also, your CMS website. I have the Texas State Department of Health because that's the state in which I practice, but certainly check your own state's Department of Health for resources regarding infection control and prevention. Certainly, we are not doing a live webinar today, so they're not question and answer time live, but if you have questions that you have after this particular webinar, feel free to reach out to us here at Axxess. You have my email address here. It's jgibson@axxess.com. You also can reach me by cell phone message or text message at the phone number that you see online. And then certainly if you're an Axxess customer, you know you can call support and have them reach me, or call directly to my extension, which is 3917. But the best way to reach me is by email or cell number because I travel often, okay? Anyway, thank you so much for being with us again today as we went over our 6th part in our 7-part series on home health conditions of participation updates. And we look forward to serving you again soon in the future. And as I often say, no matter what your position is in your home health agency, certainly know that that agency couldn't function well without you. And more importantly, the patients who are served in the home could not get the care that they need if you weren't there to do your job every day. So I just want to acknowledge you and thank you for all the hard work that you do, because I know firsthand working for home health and taking care of these patients, it's not an easy job, and sometimes it's a thankless job, but know that we here at Axxess certainly understand, and I certainly thank you for what you do. So we'll see you again next time, and don't forget to come back and listen to part 7, which will be on the emergency preparedness parts of the conditions of participation. Thank you again and have a wonderful day.
Thank you for joining our on-demand training today and for choosing Axxess, a provider of innovative, cloud-based software, services, and solutions to help home health organizations improve patient care and grow their business. Axxess is the only healthcare technology company approved to award continuing education credits by the American Nurses Credentialing Center, and is also the most recommended home health software on Software Advice. You can watch more on-demand training videos through our software or at axxess.com, where you can also find tutorials, blogs, white papers, and answers to frequently asked questions. Thanks again for choosing Axxess.